Let's talk about outpouchings of your poop chute, also known as diverticulitis. Diverticulitis is caused by constipation, which leads to increased intraluminal pressure as you try to lay a brick. This causes herniation of the mucosa and submucosa at the weakest point of the bowel wall, the vasa recta, creating a false diverticulum which allows bacteria to penetrate the colonic wall, leading to inflammation which may lead to ileus or perforation, and feculent or purulent peritonitis if not contained by mesenteric fat. The patient will have a long history of difficulty pushing out a brown trout due to constipation. They will likely be 60 or over. They may be obese, have a smoking history, eat a high-fat, low-fiber Western diet, and have intermittent left lower quadrant pain, nausea, and fever similar to a left-sided appendicitis. On exam, there may be a palpable left lower quadrant edematous mass and left lower quadrant tenderness. Labs will likely show leukocytosis and potentially alkalosis from ileus and vomiting. To diagnose, consider upright KUB to rule out perforation, then get an abdominal CT with PO and IV contrast and look for edematous thickened bowel wall, fat stranding, and diverticuli. Complicated diverticulitis will have an abscess, colovaginal or colovesicular fistula, or perforation on CT. Colovaginal or colovesicular fistula will lead to the patient reporting a larger than normal amount of stool and gas passing from their vagina or urethra. To treat a complicated diverticulitis, make the patient NPO, give IV fluids, IV Cipro or Ampingent and metronidazole, drain any abscesses with CT guidance, surgically correct fistulas electively. The patient should undergo surgical bowel resection for obstruction not relieved with medical management. And finally, a patient with perforation or peritonitis should undergo emergent surgery. Usually the aptly named Hertmann's procedure, because nothing makes you think of matters of the heart more than cutting up someone's colon, also known as proctosigmoidectomy. If uncomplicated, treat with 7 to 10 days of PO antibiotics. Cipro or Ampingent and metronidazole are options. This can generally be done at home. The patient will need a colonoscopy in about 6 weeks to rule out cancer and confirm the presence of diverticuli. Outcomes follow the rule of thirds. 1/3 will have resolution, 1/3 have a recurrence, and 1/3 have episodic pain. Recurrence may require an elective hemicolectomy, which allows a primary anastomosis due to lack of inflammation during surgery. Thanks for watching. Please like, comment, share, subscribe, and hit that notification bell for more videos like this one. Remember, if you don't want to miss it, look below and click it.